Preventing and treating skin cancer. Joining us in the studio for our Your Health segment this week is Dr. Zeynep Makhzoumi, the Assistant Professor of Dermatology at the University of Maryland School of Medicine, also a dermatologist at the University of Maryland Medical Center. Doctor, thank you for being with us.
Thank you for having me.
This is a perfect time of year to be talking about sun-related conditions, and skin cancer clearly is one of those.
Absolutely. The time is here. And no better time than the beginning of the summer to talk about skin cancer and how prevalent it is, really.
And we'll focus on prevention, but I think the way we can get people focused on the importance of prevention is to talk about what you do. You're in a specialty called Mohs surgery, which it's
right.
not nose surgery.
No, it's not
but it
nose.
can be.
I have been called a nose surgeon, but I do Mohs on the nose a lot of times. So
Where did the phrase come from? It's M-O-H-S.
It's M-O-H-S. It's actually named after Dr. Frederick Mohs, who described and pioneered this technique when he was at the University of Wisconsin in, I think, 1940, 1941. He first described this technique. He was, I think, a medical student, which makes me feel very, very behind.
Somebody comes to see you. They've been diagnosed with a skin cancer, a lesion of some sort. What do you do that's different from what a dermatologist might do in their office?
Right. Good question. So, you know, the beauty of what I do as a Mohs surgeon is that it's a really comprehensive technique where I serve not just as the surgeon, but as the pathologist. So if you went to a dermatologist and they cut out a skin cancer and they sent it to the pathologist kind of breadloafs the section, and they're looking on average at about 0.03% of that margin.
Breadloaf meaning slice.
Meaning just kind of slice it, exactly, sort of like a loaf of bread. What I do is completely different. I actually look at a horizontal margin where I'm looking at 100% of that tissue margin. So as opposed to 0.03%, there is not one portion of that tumor margin that gets beyond my eye under the microscope.
So kind of the cutting is the least of what you do, it sounds like.
Oh, absolutely. I mean, the cutting is, well, and the putting back together is definitely the fun part of what I do, but really the beauty and the continuity of what I do is that when I take out the skin cancer and I walk it to the lab, I take off my surgeon hat and I put on my pathologist hat, and I look under the microscope and I map and I see, are there tumor buds here? Are there tumor buds there? And if not, I call it clear. If there's tumor there, then I map exactly, is it at the 6 o'clock or the 9 o'clock? And I go back and I take a little bit more. And I repeat that process until I have decided that the tumor margins are clear. And then I sort of put my reconstructive surgeon hat on, and I decide how to close that defect.
In the meantime, what's going on with the patient? He or she is sitting in the waiting room with a kind of a hole somewhere?
No, not it's not that gruesome. They're actually usually across the street. We have a great deli across the street from where my practice is. Or they're watching TV in the waiting room, or they're sitting and talking with their family members with a bandage on there. So definitely not kind of walking around with holes, not stopping traffic.
When does a regular old dermatologist decide this one needs to go to the Mohs surgeon?
Really good question. So there are all these indications for Mohs surgery, all these kinds of scenarios where that patient ends up in my office. And really the most common reason they end up is location, right? Location. It's that old adage, real estate. So, you know, really prime real estate's going to be from the neck up. So anything from the neck up, it really essentially is going to be Mohs surgery appropriate. So that's probably the most common reason the dermatologist sends the patients to me. There are a whole host of other factors, most commonly patient characteristics. If that patient is especially sick, if they have a transplant, I have a lot of patients I care for at university with transplants. They are really vulnerable population. So a tumor anywhere on a transplant patient, and they're coming to see me for Mohs. And then
I'm sorry.
And I was going to say really big skin cancers. You know, a skin cancer on the back that's less than 2 centimeters doesn't cause a problem, but bigger than that, and you're going to want Mohs.
And bigger than that would be, is that fairly uncommon?
It is, yeah. I would say most commonly with regular dermatologic checkups, most people can catch skin cancers well under 2 centimeters.
Yeah,
absolutely.
And do you tend to see, I mean, there's different grades. There's the squamous cell
Absolutely.
And then at the other end of the spectrum is the melanoma. The less virulent cancers, do they go to a Mohs surgeon as well?
Really good question. I would say that 80% of what I do is basal cell skin cancer, which is overwhelmingly the most common skin cancer. There's over 2.5 million cases in the U.S. every year. So most commonly, I'm seeing basal cell. And then second most common, I see squamous cell skin cancers. Melanoma, which is definitely the most virulent, and that's the one we all worry about metastasizing to other parts of the body and really eventually ultimately causing death. Those I don't do Mohs surgery on. Those we're going to do standard excision, and we take pretty wide margins off of those.
Right. Let me remind our viewers, if you have a question about dermatology in general, skin cancer in particular, give us a call. We'll have the number up on the screen. You can also tweet a question. Our Twitter address is @MPT News. So now that we've done the gruesome description of the surgery that happens if you get one of these, how do we not get skin cancer? And are they all preventable?
Very good question. Most skin cancers are preventable. When you look at the percentages, it's about 90% of these tumors, skin cancers, that we can directly attribute to ultraviolet radiation, whether that's indoor tanning or outdoor, good old laying on the beach, sun exposure. Most skin cancer is directly attributable to ultraviolet radiation. And so, the most important thing you can do to prevent skin cancer and prevent ending up, in my office, is just to protect yourself from the sun. It's practice safe sun, as I tell my patients. If you know you're going to be outside between the hours of 10 and 4, cover up or seek shade. You have to live your life, which is what I tell my patients. I'm realistic. I know you're going to be on a beach, you're going to be on the Eastern Shore. Just be smart about it and seek shade and apply sunscreen.
Can you get sun cancer in a place that the sun doesn't reach?
That the sun don't shine on? Yeah.
Maybe your underarms or someplace where you wouldn't expect it.
You can. They're much more rare. Those types you can get caused by a virus. Some viruses can cause skin cancer. Overwhelmingly, though, it's the sun-exposed areas that tend to see the brunt of skin cancer. And you just look at the face. Well, most of the Mohs surgery I do is on the nose, and the nose, sticks out to the sun the farthest. So most skin cancers are going to be sites that are hit by the sun.
I'll tell you about my experience as a lifeguard, and there was no sun. Well, this is a long time ago, but even that zinc oxide stuff, you still get a sunburn if you're sitting out there all day.
Right,
yeah.
And you have to reapply, and that's something people say. Well, I put on SPF 20 at 8 o'clock in the morning, but when I got home at 5 o'clock from fishing on the bay all day, I had a burn. Yeah. And so you have to reapply. I tell my patients every 2 hours. That's my rule.
And get a big hat.
And a wide brim hat.
Let's take a phone call. This is Bob in Baltimore County. Bob, thank you for calling. Go ahead.
Yeah, I'm an older person who has had several skin cancers, and I'm wondering about the timing of all this. As a kid, I got severe sunburns, and I don't know if that projects forward, but also the dermatologists nowadays say even at my age I should protect myself from sun, and I wonder how old exposure and recent exposure go together.
Bob, we got it. Thank you so much for the phone call.
Yeah.
So I think what Bob's saying is that if his exposure to the sun 40 years ago caused this problem today, does he really have to worry about today's exposure projecting way out in the future?
Yeah, it's a good question, and it's a question I get a lot. And I tell my patients to wear sunscreen. I tell my 80-year-olds to wear sunscreen. And I tell them to wear sunscreen not for today or tomorrow, but for 5 or 10 years from now. We consistently see about a 5 or 10-year lag between sun exposure and the development of skin cancer. And to answer Bob's original question about sunburns, absolutely we know that sunburns are directly linked to the risk for melanoma. Having one sunburn as a child doubles your risk for melanoma.
But who didn't have a sunburn?
Right.
How do they do that study?
Right, I know, that's true, yeah, absolutely. And people didn't know back then either, so.
How about the different kinds of sunscreen? Obviously, there's a lot of different brands, and some say broad spectrum, some say UVA, UVB.
Right.
I don't know what else.
That's good. Broad spectrum. Broad, definitely always go with the broad spectrum sunscreen. You're going to want to cover UVA and UVB. And in terms of the number, everyone is so focused on the number and what do I do? Do I use 35 or 40 or 25 or 30? And I just tell people it's not the number. I mean, as long as you're above 35 or 40, I promise the number is fine. It's the fact that you're reapplying every couple hours. You can put on SPF 85 in the morning, and if you don't reapply, then you are going to get color, you're going to get burned, and you're going to get the UV radiation.
Are we sure these things prevent skin cancer? Obviously, you know that if you put the stuff on and you go hang out at the Preakness and you don't get a sunburn, that it prevented the sunburn. Is it the same mechanism? Is it possible that certain rays of the sun are still, damaging your skin cells?
Good question, and absolutely the data is there. The data is there that sunscreens are proven to reduce the incidence and the aggressiveness of skin cancers.
Let's talk to Lee in Prince William County, Virginia. Lee, thanks for calling. Go ahead.
Yeah, I want to say, I was talking about like skin cancers and the sunshine and stuff like that. It's like years ago, I think we used to be more of a farming community a few years ago. And how is it different now than it was back then? I just wanted your opinion on that.
I didn't quite catch the first part.
Years ago, we were more of a farming community, and people, I think, were out in the sun, exposed a lot more.
And you're saying they didn't get as many skin cancers?
I don't know. I was just wondering.
Okay, that's right.
On that was.
I understand. I mean, it's part of it that people live longer.
Right. Good question. And a lot of people are asking me, well, the increased incidence we're seeing, is it because there are more Mohs surgeons, there are more dermatologists, and we're just picking up a lot more and we're being more vigilant? And the truth of the matter is, no, it is a true increased incidence. Even if you say that we're just picking it up more and we're more aware, when you look and you stratify out for that increased vigilance, there is still a true increased incidence in skin cancer. It has to do with the ozone layer. It has to do with the thinning, of the protective layer we had. So no, there is a true increased incidence in skin cancer we're seeing.
Is a tan protective in some way? So I'm thinking people maybe there wasn't good sunscreen. The stuff, when I was a kid, it was intended to make you more tan, not to prevent the sun from getting through. Did that when in the summer, especially more people working outdoors, maybe they were better protected?
Right, and that's a question I also get a lot. People are preparing for a beach trip and they say, oh, can I just go ahead and get a quick tan to go ahead and provide me some protection as a base so I don't burn? We now know that that's absolutely not true. The direct cause of skin cancer is cumulative exposure, cumulative ultraviolet radiation. Every tan you get, every 15, 20 minutes you're out in the sun, that's just increasing and adding to your risk for skin cancer. And when that gets beyond a certain threshold, you're going to start developing skin cancers.
Yeah. And if that's not enough, it makes you look wrinkly.
No one wants to look like old leather. That's right.
Let's talk to Kim in Baltimore County. Kim, thanks for calling. Go ahead.
Oh, you were talking about this Mohs procedure as opposed to testing certain parts of the tumor. Am I understanding that correctly? Where you do the Mohs, you test the 100% of the tumor?
That's correct. That's right, Kim. Yeah. When I remove the tumor by the Mohs technique, I walk that tissue to the lab and I have my technician slice it, stain it, and I look under the microscope at 100% of that margin, both the peripheral and the deep margin.
Now, could the patient specify that that's what they want to have done, or is it something that is only the decision of the doctor?
Great question. I'll get you the answer on the air to that.
Absolutely, yeah. So unfortunately, there are certain indications for Mohs surgery, and we sort of have to go by those indications, and that's a function of the healthcare system as a whole. That's insurance companies and looking at the cost-benefit analysis and the cure rates. The cure rate I can get with Mohs surgery is about 99.2%. With standard excision, you're looking at a 92% cure rate. So for the back or the arm, it's not the trade-off. You just take a little bit wider of a margin and it's fine. Really, it's when you're getting to the prime real estate areas that you need that precision, you need that accuracy.
I know you're enthusiastic about the surgical treatment of skin cancer. Are there non-surgical treatments?
There absolutely are, and for the more, superficial skin cancers, definitely Mohs is not the only way, and it's not really the appropriate way to treat them. Very superficial skin cancers we can treat in the office with curettage, where I just take almost what looks like an ice cream scooper and I scrape the top of that skin cancer. I can also use liquid nitrogen, which is kind of a cold spray that you spray on, and those are sort of
there, right?
Yeah, been frozen
That's
before.
when they say we're going to freeze it off or we're going to burn it off.
Exactly, and that's what they're talking about. And what I'm referring to is the more aggressive skin cancers.
Okay, let's talk to Gail in Baltimore City. Gail, thanks for the call. Go ahead.
Yes, I have two questions about getting sunburn. One through car windows and also porous clothing, and what effect that would have on skin cancer.
Thanks very much.
Really good question, Gail, because a lot of people assume that window glass filters out the ultraviolet. We now know that that's really only part of the story. There are still UV rays that can go through window glass, and so you still need to be careful when you're driving, and you need to wear sunscreen. You can even put the visor down on that left side while you're driving. So, you definitely still need to be careful. And I believe Gail's second portion was about porous clothing. Truthfully, there are sunscreened clothing. There are a lot of companies out there making sunscreen clothing. Unless you're buying one of those, the truth is there is going to be some sunlight and some ultraviolet radiation that seeps through the clothing.
You brought up tanning beds earlier in the conversation. Is there something about that makes it even more dangerous?
Yeah, it's the same ultraviolet radiation, but you're being exposed under those light bulbs and really just diffusely everywhere. And recently the WHO, the World Health Organization, came out and actually classified tanning beds as a Group 1 substance. So that's the most dangerous cancer-causing agents. They put plutonium, I think, and cigarettes in that group. And so tanning beds are right up there. So absolutely unsafe.
All right, we'll continue our conversation after this short break. You're watching Direct Connection on MPT.
Heather Sanderson here. It's time to award an OTG to this week's loyalty supporter,
Audrey Riker of Whitehall.
Membership matters. Thanks for helping to put a smile in everyone's day.
Next time, we revisit treasures from the Cigar City in Antiques Roadshow, Vintage Tampa.
I had no idea.
I was hoping you didn't.
Oh, Mom had a good eye. Congratulations.
Can you guess what values went up, down, or stayed the same? Find out next time on Antiques Roadshow.
Tonight at 8 on MPT. Tonight on MPT.
Next time on Midsummer Murders.
A lot of strange things have been happening.
When an undertaker is killed, suspicion falls on a spiritualist group.
I want to expose them.
And when another victim dies, for Barnaby, it gets personal.
She was Joyce's friend.
So is it a spirit?
Unfortunately, sir, we can't arrest a ghost.
Or is something else going on?
As if someone's just playing at being the murderer.
Find out on Midsummer Murders.
Tonight at 9 on MPT.
And continuing our conversation with Dr. Zeynep Makhzoumi of the University of Maryland on the topic of skin cancer prevention and treatment. If you have a phone call for us, you have a question, give us a call. We'll have the number up on the screen. I did want to ask about research in this area. I'm sure there's research going into the newest, the best sunscreen. In terms of diagnosis and treatment, what are the exciting areas?
Yeah, really good question. There are a lot of new computer models that have been coming out that look to diagnose melanoma, that look to diagnose basal cell, basically just by taking an image. So you sort of hold your iPhone up there, and just like you take a selfie, right? You take a selfie of the skin cancer, and the computer models can kind of analyze that based on some algorithm that they have, and basically tell you suspicious, not suspicious, biopsy, don't biopsy, and truthfully, I have not I still find that my good old eyes are probably the best in my clinical judgment. So I don't use those in my practice, but I know there's a lot of research that's going into these new picture and computer models.
How much of it is a judgment call? Is it a subjective look by a trained practitioner saying, yeah, that doesn't look good. I don't like the way that looks.
Yeah.
Versus some objective standard.
There are definitely objective standards I use, and I tell my patients at home, because they're only seeing me, once every 3-4 months for my regular dermatology patients, and for Mohs, they're already diagnosed. So what I tell my patients is really, for melanoma, it's the ABCDs. You want to look for any asymmetric mole, any mole that has irregular borders, any mole with color variations, and any mole with a diameter greater than 6 millimeters. And using those ABCD criteria, if any mole fits that, then they need to be on the phone with me.
Frankly, the picture of that they have sitting in the dermatologist's office, you wouldn't need a medical degree to say, I got to get that thing looked at. But sometimes it's more of a judgment call.
Absolutely, that's true. And a lot of my patients, I guess I'm pretty fortunate. I have really smart patients, and they know that if a spot comes up and it's painful, that's a trigger. Skin cancer grows around nerves, and so if there's pain from a spot, that could signal that it's a skin cancer. Anything that's bleeding, my patients know to call me with a bleeding spot, and so I have very, very intelligent patients who sort of have been through this before, so they know what to look for.
Let's take another call. This is Bob in Baltimore City. Bob, thanks for calling. Go ahead.
Hi there. My name is Raul from Bowie, and I wanted to ask a question.
Okay, you're on. Go ahead, Raul.
Well, thank you very much. I had a question, and it was it regarded getting into a tanning bed and smashing my apples.
I don't know where that was going. I think we covered tanning beds pretty conclusively there. So on the dermatology front, the idea that some things require maybe a closer look. Do people at a certain age need to go in once a year, even if they don't have any history, they don't have a family history?
Absolutely, and just like you would change your oil, just like you'd take your car to get your oil checked, you still need to get a skin check. And anybody really over the age of about 50 or 55, just like they see, the mechanic once a year, they need to be seeing a dermatologist once a year just to get a checkup, make sure that one of us says you're good to go, until next year, or if something changes, call us before.
Frankly, dermatologists can be some of the hardest medical specialists to get appointments with. In my experience, just a little bit around town, population's aging, there's a lot of people who need to get looked at. What's your advice there? And where practices have a physician assistant, how comfortable should somebody be in seeing the PA as opposed to an MD?
Absolutely, Jeff. That's a question I get a lot. And it really, it depends. We have a physician assistant in our practice, and she's fantastic. And that's sort of the message I've been getting from other friends of mine who have that same model. And it just depends with how comfortable you are. In terms of getting in to see a dermatologist, it can be tricky, it can be difficult, but it's just a matter of being persistent. And if really a spot is worrying you and you have a bleeding spot, then that absolutely has to be evaluated by someone.
And your regular doctor may be able to help grease the skids, get you in someplace.
Definitely.
On the subject of the physician assistants, though, it's an interesting thing because they specialize more than anybody, and that's all they do, really, is look at bumps and things, and in some ways they probably have more expertise in it than the family doctor.
Yeah, absolutely. Like I said, the physician assistant we have, this is all she does. And so, absolutely, I trust her implicitly. I trust her clinical judgment. I trust her skills. And so it really just depends, I think, on the situation.
And bottom line on Mohs surgery, stay away from it if you can, but if you need it, you need it.
If you need it, you need it, and we're not so bad. We're pretty nice.
That point was proven tonight. Dr. Zainab Makhzoumi, University of Maryland Medical Center, University of Maryland School of Medicine, thanks for being with us.
Thank you for having me.
Appreciate the time. Join us Thursday at this time for Your Money in Business. It is a rematch between the U.S. government and Washington's football team on the subject of the Redskins trademark. We'll talk about that Thursday at 7:30. Now, for all of us here at MPT, I'm Jeff Salkin. Thanks for watching Direct Connection, and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.